All right, good evening. So this is Professional Readiness. This is one of the chapters from the Phelps Intervention, Treatment, and Recovery book. And this is being recorded also for later use. So we've already done this. So this is the schedule for tonight. We've already had our community resource presentations. We've already done our burp and practice and discussion. And so now we're moving into the professional readiness. And remember, as we continue on, we've already been talking about the transdisciplinary foundations, right? So foundation 1, understanding addiction. Foundation 2 is treatment knowledge. Foundation 3 being application to practice, which is kind of where we are at the moment, along with professional readiness. So some of this stuff does overlap, as you will see. Continuing on with the competencies, right? So competency number 18, remember there's 123 of these, by the way. So there's a lot of competencies. Are you expected to have them all memorized? No, I think what's important to know is that to be an effective counselor, there's lots of things we have to put into practice. So for this particular thing, right, we're talking about understanding diverse cultures and being able to incorporate those needs into culturally diverse groups. So for example, tonight during our burp note practice, Fabian, our client, was talking about his bicultural experience, right? So his mother being from the South, I believe he said, and then his father being from Mexico and a naturalized citizen, and how the cultural differences can impact that. And so you would want to be aware of that in order to incorporate those in your practice. And then also incorporating and being aware of individuals that may be experiencing symptoms of disabilities. Some can be seen, some can't be. You have a client in a wheelchair, that's pretty evident. You have a client who has a hearing problem, not so much. And so, so we need to assess and kind of gather that information. Also understanding the importance of self-awareness in one's personal, professional, and cultural life. And when we talk about self-awareness, we're talking about our own as counselors. And then understanding the AOD professionals, obligations are to adhere to ethical and behavioral standards. And this is really important. So this is where having those boundaries, knowing that, so here's an example. So, you know, one of the ethical responsibilities or guidelines for AOD counselors is to not engage in relationships with clients, right? So that be friendship, intimate relations, sexual relationships, dating, anything like that, right? That is crossing an ethical boundary. Now, CCAP and Katie and NADAC all say that after 2 years that's okay. I actually disagree with that. Once a client, always a client, and there's always going to be some power differential. And I think it's really important to understand that when we're engaging in our helping relationships with clients. And then of course, and this is really important, understanding the importance of ongoing supervision and continuing education. So, you know, when we're writing our burp notes, you know, we're asking about how are we applying EBPs or evidence-based practices, right? And the best way to stay up to date with that is through continuing education. Also, seeking supervision. So if you're new in the field and you're not certified yet, you have to be supervised, right? So there's a training process, and even after you're certified, you know, as Teresa Whitney always says in her law and ethics course, and if you haven't had her yet in law and ethics, you will, and you'll hear this. But seek supervision before supervision seeks you. Because usually if supervision is seeking you, that means they've discovered something, there's probably a problem, and it's much better to be proactive than reactive, right? So if you're really unsure of something, seek out supervision. And then also understanding the obligation of the AOD professionals to participate in prevention and treatment activities. So one of the things we used to talk about in here is prevention. There's a whole thing, you can be certified in prevention activities. But what I think about here is like relapse prevention, and obviously other treatment activities such as counseling, group assessment, intake, orientation, the things we're going to be talking about later on in this lecture. Oops. All right. And then understanding and applying setting specific policies and procedures for handling crisis and dangerous situations, right? Including safety measures for clients and staff. So, you have a client who's in crisis, making sure that you know and you understand what the policies and procedures are. What do we do when a client is in crisis? What do we do if there is something dangerous that's just occurred on site? And how do we protect clients? How do we protect the staff? And also, also thinking about how do we protect clients as well. All right. Any questions on those competencies that we've kind of talked about? Any clarification needed? All right. Not hearing anything, we're going to move on to the 12 core functions. And as I said a minute ago, some of those competencies that we kind of talked about, and orientation, intake, all that kind of stuff, we're about to talk about with the 12 core functions. So the first of the 12 core functions is screening. And this is where, so here's the purpose of screening. The purpose of screening is to determine whether the person that is coming to you as a referral, or whether it be self-referral or whatever, is appropriate for your program, number one. Do they meet the criteria? Are they eligible for admission to a particular program? So I'll give you an example. So earlier during the community resource presentations, there was discussion on eligibility for like insurance, self-pay, what's accepted, what's not accepted, right? So sometimes those kinds of eligibility requirements. Do they meet the age eligibility, right? So if it's a 15-year-old coming into your program and you are an adult only program, they would not be eligible, nor would they be appropriate, right? So screening is designed to do that. It's a form of assessment, but it's a simple assessment, right? So who gets in, who doesn't get in, right? That's part of it. And then some of the global criteria that we want to talk about is we're going to be evaluating those psychological, social, and physiological signs and symptoms of SUDs. So when I'm doing screening, I'm actually assessing if they're appropriate for my program, if they have an SUD, right? So if they don't meet criteria for a substance use disorder, well, you're coming to a substance use disorder treatment program, you don't meet the criteria, right? And so that would be part of determining their appropriateness for admission or even referral at that point. Their eligibility for participating in there. Also identifying if there are any other coexisting conditions. And of course, here in San Diego County, last week we talked about the ASAM criteria. So part of our screening process is using the ASAM criteria. If you already work out there and you're taking county money, you know exactly what I'm talking about. For those students who have not gone out into the field yet, the ASAM criteria in that part of the screening is what we're looking at, all of these different items. So medical history, psychiatric history, physical stuff, uh, and and of course substance use disorder, um, risk for continued use, current intoxication or withdrawal symptoms, things like that. Any questions on screening? All right. So screening occurs. The person is determined to be appropriate. They are determined to be um, eligible, and so there's nothing really standing in the way of intake. So that referral now becomes an intake. And an intake is a couple of different things. One, it's your initial assessment. So we've done the screening, which is a simple assessment. They come in, you are doing more assessments. You might do what's known as so if you're an adult program, you would do the adult initial level of care. So you're going to assess them for the level of care that they need. Yeah, you would also do that during screening too. And the other thing that you would do is the administrative side of it, which is you're talking about ROIs, in other words, releases of information or authorizations to disclose, those kinds of things. Other paperwork would be done during this time. So another way of saying this is you're in, but you have to sign and date a million forms first. So anybody that has conducted an intake, there's lots of paperwork, crossing the I's, dotting the T's, correction, dotting the I's, crossing the T's, getting that all messed up, right? So we're going to be completing the required forms. Might be admission agreement, coordination of care with the doctor, those kinds of things. CFR 42 Part 2 forms. Trying to think what else. I'm trying to go off the top of my head. Health questionnaire, those kinds of, there's just lots of forms that would be done, including consents as well. Let me see here. Any questions on intake?
So Professor, it's Eminem again.
Sure.
Because I work at adult detox.
Yes.
So ours are a little different because one of our requirements is that they're intoxicated. Right. And then during an intake could be very, very challenging because as they're nodding out or puking or need to get to the emergency room for withdrawal medications with their, like you said, their ROIs, we have to have those all. Poor things, we're like almost forcing them, shoving it under their nose to, so that we can make that step so that we're able to transport them to get that special help.
Yeah.
So it's just a little different. Yeah.
And I totally hear what you're saying. One of the thoughts that come to my mind here is that actually puts us in a pretty precarious situation, doesn't it?
It does.
Because legally, if they are acutely intoxicated, can they really agree to treatment?
A lot of times they don't remember.
Yes, exactly. Yeah. And so, so that's one of those more unique situations, which is another reason why a lot of places will say, yeah, we can't do intake with you if you're under the influence, right? You have to be abstinent for 24, 48, or 72 hours, whatever the requirement is, right?
Wow, I didn't know.
And so, I mean, there are some places that won't do that.
And you got to be able, stable, and willing.
Exactly, and the way you demonstrate able, stable, and willing is being able to participate in your own intake. Now, as I say this, I realize I don't want to make anyone uncomfortable because, again, I don't know your individual programs. So whenever I'm making statements like this, it's very broad, very general. There are always going to be program-specific stuff. I'm going to assume that there are safety procedures in place. right?
Yeah.
And that I don't know everything that's going on in a particular program. I was just kind of bringing that up as, that's one of those things that, so what do we do? How do we handle that? And it might be that after we do that, we get them their medication, they sleep it off for a day, that we re-review the forms with them, right? So that they're, I don't know what the procedure would be. Yeah, but that's one of those very unique situations. I've never worked in detox. I don't, I don't know that I could. Bless you for doing that. Um, so yeah. Let's see. I thought I saw someone's hand raised, but
Oh yeah, it was just me.
oh, okay, cool. All right. So good. Thanks for throwing a wrench into my lecture. I'm just kidding with you. But it brings up these things. These are things we always have to think about, don't we? Because when they're signing these forms, here's the other thing. When it comes to signing these forms, the clients should get a copy of the forms that they're signing. So, and that's something that's like really important that sometimes gets forgotten. I know it has in programs where I've worked at, and it's like sometimes we're just trying to get through the intake so fast. And that's another thing I disagree with. I don't think it should be a rushed process. The clients should understand every step of the way, and then get a copy of their releases, get a copy of, their admission agreement that tells them, what the cost is going to be, right? They should be getting copies of certain forms because they have a right to those copies. Any other questions on intake? All right, then the next thing we do is orientation. Orientation is really a very important part of what happens with a client. By the way, you're using MI all through this, right? We're rapport building, we're being safe, therapeutic, we're being warm, inviting, right? I did forget to mention that. You're going to do that at screening, you're going to do that in intake, and of course, it's going to continue on with orientation. And the important thing about orientation is this is where you're explaining to the new client what to expect. What are the goals of the program? What are the general rules, right? What are the costs? What are the hours? What to do if they're experiencing, like I work in outpatient, right? So working in outpatient, we're closed. And right now we're closed. So if one of our clients is having a crisis, what do they do? So orientation kind of gives them that kind of information, right? It tells them about what their client rights are. We talk to them about grievance procedures, rules that will govern their conduct, right? And things that will lead to disciplinary action, including discharge from the program, right? So all of those things are done during orientation. So in other words, this is who we are, this is what we do, and this is how we do it. It also talks about what's my role as a clinician, what's your role as a client, and then what are your rights as a client. And then, of course, the global criteria here that we're talking about is providing that overview to the client, describing the goals and objectives, and then describing the rules, obligations, rights, and then also providing that overview, looking at global criteria number 11, providing that overview of the program operations, which I kind of already described in the beginning. So when it comes to orientation, are there any questions? And then there was a comment that says, come in, tell DMC ODS that. Tell them what? I'm not sure which part, because there's lots of things that sometimes
that was referring to how long an intake should take.
Yeah. Yeah. So I think they give us what, 60 minutes or something like that.
Something silly.
Yeah, something like that. But if you're smart and you know how to break something up from into an orientation and then into an individual counseling session, you can actually help the client out more and then have your time covered because you're using MI and you're, yeah. So there are ways, but you're right. They do limit
60
that.
minutes.
What's
Wow.
that?
60 minutes, huh?
Yeah, like 60 minutes, I think. I forget
Oh,
what it is.
okay.
It might be
Wow.
90, but I can't remember. All right. Then the next thing we do is assessments. And so I know I talked about screening. I know I talked about the initial level of care, whether it's adult or juvenile. And then, we talked about orientation, but those other two items are kind of forms of assessment. But for this particular core function, this is where we're talking about the official assessment, like the ASIs and behavioral health assessments, things like that. And this is where we're identifying and evaluating that individual's strengths, weaknesses, their problems, and their needs. And the purpose of this is actually for the development of a treatment plan. So when you do the addiction severity index, anyone that's done it knows that it's kind of like sorry, I lost my train of thought. That it's kind of like a biopsychosocial, right? So we're looking at their physical health, we're looking at their recovery environment, we're looking at their social environment, things like that. And really, you can also translate the ASI into the 6 dimensions of ASAM. So and an ASAM LOC is also required, level of care form is also required before doing a treatment plan. So that's all part of the assessment process. So in other words, it's what brings you here, what do you want, right? What do you want to get from treatment? And then what do you need, right? So that's the purpose of the assessment. And, going back to like the ASI, I'm using that because that's probably the most common one that people use. I think that's the only assessment that the county pays for SUD programs. For mental health programs, they also pay for the behavioral health assessment. But anyway, the purpose of that is to gather history, and it's not just limited to substance use, right? It's limited to, it's not limited. It includes their early childhood development, education, employment history, those kinds of things. The other thing is, it's also, this is another way you can also obtain like collateral information from secondary sources regarding, the client's biopsychosocial history, assuming you have the appropriate releases, by the way. So going back to the example, that one question that was asked earlier for the TTM paper, with the parent coming in with the adult college students, right? So the two of them come in together. As long as the appropriate releases are signed and the adult child is actually agreeing to have the parent there, then it's okay to have that, to gather that collateral information as well in your assessment, right? So, and then also you're developing that diagnostic evaluation. We kind of talked about diagnosis last week. We'll be talking about it again. We'll do some practice in class on diagnosis as well in preparation for your diagnostic summary paper. But that's all of what we are doing with assessment. It's a very formal process at this point. All right, so let's see. Yeah, so somebody says they're currently doing the ASI online. It doesn't really matter how you do it. You can do it in paper form. There are EHRs, like we had an EHR called Avatar that they had actually input the ASI into that, and it would save it in the client's record. If you do it online, you can probably do a printout and get those results. Really, we're talking all the same same way, regardless of the mechanics of how you're conducting it, the assessment. So it can be on pencil and paper, or electronic, or in an EHR. All right. Oh, sorry. So any other questions that came through on chat? It was a comment on chat. Any other questions regarding assessment? All right. And as I suspected, looking at the time, I'm only going to get about halfway through this, which is okay. We'll pick up in the next session. But now we're moving on to treatment planning. And you'll notice that there's a little SMART goals icon up at the top. I want to kind of talk about SMART goals for a moment. SMART basically means specific, measurable, achievable. Up here it says realistic. Realistic is there. Some people say rewarding, others say relevant. I like any of those. And then, of course, timely. So in order to have a SMART goal, it has to meet all of those criteria. But treatment planning is the process by which, the counselor and the client together identify and rank problems needing resolution. And I say that together. It's really important that when you're working with your client on treatment planning items, that you're having a discussion about some of the goals that they want to meet. And I will say, okay, so I'll tell you how I handle treatment planning. Generally, when I know I'm going to do a treatment plan for a client, we set up an appointment to actually do that treatment plan. And let's say it's going to be a week from today. Okay, so next Monday, Johnny, you and I are going to do our treatment plan. But for today, during today's counseling session, let's talk about what things we might want on that treatment plan. I use different tools, like what do you want from treatment? There's a form you can use. You can sit down with the client and go, okay, so what do you think your top problems are? And you can start hashing out this discussion already. I think that's a great way to include the client in treatment planning. And that can be in that one individual session. Then when you guys come back, guess what? The only thing you have to do now is kind of just type it up together and see if there's any changes or any new items. And maybe you come up with some more action steps. But a lot of the work is done. Sign a date, and then you're good to go. LPHA has to review it. But it's a process where the counselor and the client are doing this together. Now, the way I described it isn't the way it has to be done. It's just a way I do it. Different programs may have different ways of introducing clients to treatment plans and things like that. And really, for the initial one, a lot of clients don't know what treatment plans are, right? So taking that time to have that conversation with them can really help them. So in other words, what we're going to do is we're going to collaborate to create short-term goals, long-term goals, and making sure that they are unique to each client. So no cookie cutter treatment plans. Back in the day when I first started, in this career, I used to see a lot of cookie cutter treatment plans where it was almost the exact same wording.
Scared the hell out of me.
What's that?
Oh,
Oh, just make sure you're on mute. All right. Yeah, so you want to make sure that it's unique to the client and that it's meeting their goals. Now, there are some things I will say with treatment planning that are requirements. For instance, as was discussed earlier before this lecture, during one of the community resource presentations, that physical exams are required, right? And so if a physical exam hasn't been obtained by a client within the previous 12 months, then they have to get one. Well, that has to be put on the treatment plan. What I used to see, and it used to drive me nuts, I'll be honest, is the treatment plan would say, here was the problem. The treatment plan would say, the medical director has not been able to review the client's most recent physical exam. That is not a client problem. That's a program problem. So a better way to really state that is to ask the client, so how has your substance use affected your physical health? And they might say, oh man, yeah, I've been neglecting it. I haven't been to the doctor in forever. I've got this abscess I need to go get checked out. I discovered last year that I have Hep C, and I've never gotten treatment for it, right? So now we're talking about what the real problem is for the client. So instead of saying that the problem is the medical director hasn't been able to review the physical exam, no, that's not the problem. Throw that out. The problem is the client has been neglecting their physical health because of their substance use behavior, and that they have certain health needs that need to be met. That's what you would put in the treatment plan. That would be the problem. And then, of course, the goal would be to be referred to a primary care physician. Action step would be to obtain the physical exam, have to be turned into the medical director or something along those lines. I'm just kind of throwing some things out there. But does that make sense? I'll shut up for a minute. Paul.
I definitely embrace the idea of unique treatment plans and person-centered recovery.
Yeah.
I also understand that you have to be really careful what you put in the treatment plan, because if you do something that's not written in the treatment plan, they can deny billing the county.
Yes, they can. And so that's why you want to put as much as you can in the treatment plan.
Right. So one of the things that I will admit I'm kind of guilty of is that I will use not cloning, but similar language in regards to reviewing things like CBT, REBT, relapse prevention, psychoeducation.
Oh, you're talking about. Sorry, I didn't mean to cut you off.
No, that's okay. Just like in the goals and action steps, any tips on how to differentiate that so that it doesn't? I mean, I never copy and paste it, but if an auditor were to look at like half a dozen of my treatment plans, that language is going to be really similar.
Yeah, what you're talking about, what I hear you saying, so correct me if I'm wrong, what I hear you saying is you're talking about what the counselor interventions are going to be.
Right. Those are the way that we write up our treatment plans at my facility is that you're putting in the action steps for what you're going to do, case manager is going to do, client, all of that goes into the action steps of the treatment plan.
Right. So, and that's just good practice in treatment planning anyway. What is the client going to do? What is the counselor going to do? Right. Mm-hmm. So I think, and this is just my experience, and I don't want to get myself in trouble, especially since I'm being recorded. Here's what I'll say. I think the way you're describing it is probably okay. Because if I'm working with a client who is experiencing anxiety, there are some evidence-based treatments that we do for anxiety.
Sure, grounding techniques, things like that.
Exactly. And so is that really cloning? If I'm going to say with Johnny, I'm using, he's experiencing stress and anxiety, so I'm going to use grounding techniques. For Tommy, he's also experiencing it. It's a little bit different, but I'm going to use this as well. Is that cloning? I would argue that is not.
Okay.
Does that make sense?
Yes, definitely. I just wanted to make sure I wasn't doing something wrong.
Yeah, no. I think what's really important is that you're really individualizing the client stuff, because if they can go from one treatment plan to another and see that what the client's identified problem is and what the client's action steps are going to be, right? If those are individualized, they're not going to look at, and the counselor saying they're going to use CBT every time. Well, yeah, CBT is an evidence-based practice for a substance use disorder, right? REBT is an evidence-based practice, right? So I don't think that they're going to pick you apart on that.
Okay.
That's just that's my opinion, my experience, and it's anecdotal. I haven't done research, so
I appreciate it, Professor.
Yeah, take it for what it's worth. But it's a great question. And I'm glad you're thinking about this, because I often encourage the counselors that I work with, I'm like, we need to be thinking about how we're doing these treatment plans. That is another thing that I don't think should be rushed, which is why I say, don't wait till the appointment to actually do the treatment plan to talk about the treatment plan. You should be talking about treatment planning from the very first session when you're establishing rapport. So by the time you get to the treatment plan, you already have a really good sense of how it's going to be individualized and meet that client's needs. All right. Any other questions on treatment planning?
Professor Simonell,
Okay.
about how long, and I know it's different, but how long do you think is a good time for treatment planning?
Oh, roughly 60 minutes.
Okay, thank you.
And if you're following the suggestion that I'm making, talking about treatment planning even before you actually get in the room to do the treatment plan, right, during regular individual sessions, when it comes time to do the treatment plan, you only need 60 minutes because most of it is you're just typing it up, confirming. There might be some minor changes to it, but for the most part, you'll get it done in 60 minutes.
Right. Okay, thank you.
And I think that's all they pay for.
Gotcha.
Yeah. So that's why you want to use your other individual sessions and case management sessions. I always say work smarter, not harder. And there is nothing inappropriate on at all of having an individual session where the topic is goal setting. What do you want to work on? What do you want to look at? What are your, right? There's nothing wrong with that at all. And then the next session you do a treatment plan where you actually formalize it out in a document, because that's what the treatment plan is. It's a formal document dictating where this client is going to go through their treatment regimen. All right, and on that note, it is about 5 minutes before the end of class, and as I suspected, we're only halfway through. So tonight I will upload part 1 of this lecture, which is what this will be. But don't go anywhere. I'm going to go ahead and stop the recording, but stay right where you are.